Good. Hello, everyone. Today we're here to talk to you about the association between static and dynamic Q angle of the knee during a lunge in individuals 18 to 25 with a history of knee injury. My name is Cole Jacobs.
I'm Cody Reese.
I'm Cole Fox.
I'm Sydney Tigas.
As you can see here, we have 5 objectives laid out that highlight the key important parts of our presentation. We'd like you to take a moment here to read these objectives on your own.
Q angle is defined as the angle formed between the quadriceps muscle and the patellar tendon. Normal Q angle is between 12 and 20 degrees, where previous research has shown that males fall at the lower end of this range at approximately 12 degrees and females fall at the higher end of this range at approximately 17 degrees. Greater Q angles can result in future knee injury as well as possible surgical interventions. Previous research has shown that greater Q angles can pose different stresses on the knee that can be damaging to the ligaments and cartilage within it that may be a result of surgical interventions that can be debilitating to athletes in the future. Q angle can be measured by 3 different bony landmarks: the ASIS, the midline of the patella, and the tibial tuberosity, as shown in the figure to the right of the screen. Forward lunging promotes functional patterns. Previous literature has shown that forward lunging can also be associated with ambulation as far as the reciprocal arm and leg pattern, as well as increases of muscle activation of the quads, hamstrings, and glutes as opposed to functional squatting. Greater BMI can play a factor on Q angle and increase forces on the knee. Greater BMI can result in a greater Q angle, which also can be damaging to the cartilage and ligaments within it. That can also pose different stresses on the knee as well.
So the purpose of our study is to discover if there's an association between the static and dynamic Q angle of the knee during a lunge with a history of knee injury. We had several hypotheses that we wanted to test for during our study. Our first primary hypothesis being participants who have increases in measured Q angles will correlate with increases in number of previous knee injury history. Our secondary hypotheses state that there will be an increased Q angle in females versus males with dynamic and static lunges, and then there will be an increased Q angle with increased BMI during static and dynamic lunging. We had 30 participants in our study, recruited from Clark University based off convenient sampling basis. We were able to only, unfortunately, analyze 26 of these videos due to the deletion of 4 videos by Dartfish during analysis. Participants were included in our study if they're 18 to 25 years old, were physically cleared to perform a lunge based on a University of Wisconsin-Madison ACL rehabilitation protocol. We felt that this was appropriate because the ACL is a more common injury, but is also one of the longer surgeries to recover from. We also included these participants if they had no current musculoskeletal injury affecting the lower extremity. Participants were not allowed to participate in our study if they had recent severe knee injury, they had a general lower extremity injury, or had surgical intervention within the last 3 months. We identified several variables during our study, the independent variables being the type of lunge, whether they're static or dynamic, the sex of the participant, male or female, and then the participant's BMI. Dependent variables we noticed were the Q angle of the knee during the lunge, and then the patient's subjective or participant's subjective report of their knee injury history.
Participants first filled out an informed consent form upon entry to the room, followed by a subjective questionnaire. The subjective questionnaire determined if they had any past knee injury history or no injury history, as well as demographic information such as their sex and their age. We also took their height and weight for future BMI calculations, and then we determined their leg dominance by placing a ball on the ground at their midline and then instructing them to kick it with whichever leg they preferred, and you can see an image of that on the screen there. We then placed skin stickers on the 3 bony landmarks for Q angle measurement that Sydney mentioned before, that ASIS, midline of the patella, and the tibial tuberosity. Next, we observed the 3 different conditions First was static stance. We just instructed the participants to stand about shoulder width apart when they're just their comfortable standing position. We then looked at their static lunge. So we just had them lunge forward on each leg and come back to standing. And then the third condition was a dynamic lunge where we had them go to the back of the room and take 4 lunges towards the camera, and just to keep their lunges in between those markers shown on the screen. So we took BMI from the height and weight that we measured on a standard scale. We then used Dartfish 2D video analysis, Team Pro version 7.0, to analyze QAngle, where we could see those skin sticker placements on the bony landmarks from the video, and then we could use Dartfish to get the measurements by placing an angle on there. And the QAngle measurement is a supplementary angle, so just taking 180 minus whatever angle is shown on the screen. We also were able to standardize our lunge by placing taped lines that span the length of the room, and then that was 16 inches apart, and then again allowing the participants to self-select their lunge and just to keep it within those 2 lines. BMI was calculated with the standard equation shown on your screen there. We also used IBM SPSS software version 24 for statistical analysis. We ended up using Spearman's correlations between QAngle and 4 variables that included sex, BMI, whether they had a previous knee injury or not, and then the 3 conditions, the static standing, and then the static and dynamic lunges. We also would like to note that we had to transform some of our data all by 18 degrees. This was to account for several participants who had excessive varus knee QAngles upon measurement. And then our results moving forward will reflect this change.
Between sex and static lunge on the right leg, where R square value was seen to be 0.45 with a p-value showing significance of 0.02. This table just demonstrates the transformed static right lunge where the correlation coefficient was 0.45, which also had a significance of 0.02. The next result that we found was a strong positive correlation that was found between static stance and static lunge on the right leg, where the R square value was 0.551 with a p-value showing significance of 0.004. This scatter plot just demonstrates that positive correlation due to the trend line heading in the positive direction. The next result that we found was a strong positive correlation between static stance and dynamic lunge on the right leg, where the R square value was 0.818 with a p-value showing significance of 0.00. This scatter plot just demonstrates that positive correlation due to the trend line heading in the positive direction. The last result that we found was a strong positive correlation found between static lunge and dynamic lunge on the left leg, where the R square value was 0.609 with a p-value showing significance at 0.001. This scatter plot just demonstrates that positive correlation of the left leg during the lunge due to the trend line heading in a positive direction.
As Cody stated previously in our presentation, we wanted to determine if there was a correlation between QAngle and previous knee injury. Our results did not support this or find any significance, therefore our hypothesis is not supported. Our secondary hypothesis was to determine if there's a correlation between sex and QAngle. This was also not found any significance in our results, so therefore it was not supported. We did find one measurement that was significant between sex and static right lunging. This may be due to the female pelvic alignment or hormonal changes that may have occurred, but future research needs to be performed to discover this in further detail. We also wanted to see if there's a correlation between BMI and QAngle. This was also not supported in our research and not significant. Previous research by Pratchke et al. Did find significance between these 2 variables.
We did note several limitations upon completion of our study and throughout our study, the first of these being our small sample size of 26 participants. The next limitation we noted was any human error that could have occurred when placing skin stickers on the participants between each one, as we had one researcher doing those measurements. And then just the use of skin stickers in general, because as we found out, when people would lunge, the skin would obviously move, so the skin stickers would move, so they weren't exactly the most accurate, so it could have swayed our results that way as well. And then we also only took one dynamic measurement per leg during that dynamic lunge measurement. We had them do 4 lunges as stated before, but we only analyzed the second and third, so 1 on each leg. Ideally, we could have taken more dynamic measurements there. And then we also noticed some compensatory mechanisms, as again, we did allow them to self-select their lunge within those lines. So we noticed some would try to compensate for narrower or wider bases of support, or some had shorter or longer stride lengths. And then the last limitation we noted was the unfortunate deletion of 4 videos during dartfish analysis. And then some future implications for future research. We noted that it would be interesting to see a similar study like ours done with just a larger sample size to see if the increased sample size would lead to significant results between groups, because we did see some good correlational data. And then also, if it would be interesting to see if larger changes in QAngle between the different lunging conditions would show some significance. So looking specifically at dynamic and static lunging and seeing if larger changes in QAngle would correlate with knee injury history. And then the last implication, seeing if the effect of performing more dynamic consecutive lunges on each leg would lead to significance, as we only analyzed the 1 per leg. So if we were to have more dynamic measurements, we'd have more QAngles to measure, more data, and thus possibly some significance seen.
So in conclusion, our primary and secondary hypotheses were inconclusive because we did not find any significance between the QAngle and previous knee injury. We did, however, find a positive correlation between the static stance and lunging on the same leg. With these significant data points, it would be interesting to see the potential that these data points have on future research, since we were unable to pursue them ourselves since they did not support our primary or secondary hypothesis.
Although we did not find any significant results between our primary and secondary hypotheses, it's important to know that QAngles may be associated with greater risk of knee injuries in the future. This may be due to a variety of different imbalances within the body, first including muscular imbalances, second skeletal muscle alignment issues, ligamentous or cartilaginous issues, neurological deficits, or incorrect form during functional activities. When we are rehabilitating our patients, it's important to note these different abnormalities when they're completing functional tests. That way we can break them down into either open chain exercises or closed chain exercises in hopes that they translate into function and prevent the future knee injury in the future.
We would like to thank our advisor. We would like to take this time to thank our advisor, Brett Gussie, Professor Lori Hyatt, Chair of the Department, Jen May, as well as any other professors that may have helped us along the way. We'd also like to thank our participants for helping us during the study, and then our family and friends for the encouragement that they have provided for us throughout this process. Here are our references, and that concludes our presentation. Are there any questions?